So next we have the Auditor General report on Ontario's opioid strategy. So the purpose of the presentation is to give an overview of the 2024 report, and it reported significant gaps affecting First Nations communities, and the purpose of an Auditor General is to be independent from the province, and it oversees accountability and finances. The report was able to highlight Ontario's current state of opioids. It showed that opioid-related deaths and ER visits have increased 292% in the last decade. It has replaced consumption and treatment services with 19 new heart hubs and an investment of $378 million across the province. It found that the highest opioid death rates occurred in northern communities, and that the ministry's actions were insufficient for addressing Indigenous and rural needs. And it also found that the issues from 2016 remain unaddressed, so access to comprehensive care for opioid addiction, access to opioid therapy, access to care, and a lack of investment in research. The report also found systemic weaknesses within the mental health and addiction system. It showed that they're currently operating within a fragmented system with no clear accountability. This refers to multiple parties working in silos with no well-defined leadership or accountability structure. It found that only 10 of the 24 performance indicators were tracked, and that they had a weak outcome tracking and reporting system. So the official findings of the Auditor General for the Ministry of Health was that the Ministry of Health did not effectively implement the 2016 opioid strategy. It did not oversee and coordinate evidence-based services for people who require opioid-related services. It did not adequately monitor prescribing and dispensing practices. It did not measure and publicly report on the performance of publicly funded services, and it did not provide an evidence-based case for the introduction of heart hubs. So these findings allowed the Auditor General to issue recommendations to the Ministry of Health. On this slide, they're specifically referring to the strategy. So they're recommending that the Ministry of Health develop a holistic strategy with best practices to create a governance and accountability structure, to define outcome-based performance measures, and improve overall provincial data collection and evaluation. In relation to recommendations for service models, for heart hubs, they recommended that they plan carefully and engage stakeholders. This also refers to Indigenous communities, and to measure outcomes to ensure that this approach is effectively providing access to care across the province. For opioid agonist therapy, they want to expand access to the service. It is a medical treatment for opioid disorder and involves the administration of medications, which alleviates cravings and withdrawal symptoms. And this type of therapy is crucial for those who struggle with opioid use, often combined with counseling and support services. And this is, they're recommending that they ensure all medication options are available. For rapid access addiction medicine clinics, they wanted to evaluate their performance, improve their access in community, and to standardize metrics for which they're monitoring and evaluating their services. Specifically for naloxone, they're recommending that they monitor claims closely and to reduce inappropriate billing. For prescriptions and monitoring, they recommend that they track prescribing and dispensing practices and promote reporting. Okay. And the last one is emerging practices. So evaluating other jurisdictions and models to see which approaches are working appropriately with the population.
Okay, Helen?
We have one of those RAM programs here that we have no control over. That's that one at McNaughton's Plaza up on Silver Springs Road. I don't know what that man's name is. Does anybody remember his name? Anyway, it says they're RAM programs, they're supposed to be monitored. Who monitors him? Because as far as I can tell, nobody's monitoring him. He's just doing what he wants.
So it is Dr. Dillon that runs that clinic, and it's a methadone clinic. And you're correct. We have requested that there be oversight, and he has come to council, and you've made that request for statistics and whatnot. It's never been received. Okay, go ahead.
And I was able to provide an analysis from a First Nations perspective. So this is an opportunity to advocate for increased Indigenous funding for addiction services, to enhance our Indigenous specific data collection and evaluation, to recognize traditional healing practices, strengthen our relationships with Ontario Health and the Ministry of Health. And with the closure of consumption and treatment services, the impacts on Indigenous communities is not clear or known at this time, and that these services have been able to prevent 21,979 overdoses from 2020 to 2024. And then the bottom is just noting that Six Nations Heart Hub application has been denied, and that this is an issue across the board, and there should be equal consideration for Indigenous communities in accessing provincial investments and initiatives.
Because our closest heart hub would be London, right? Mm-hmm.
Some of
I believe it's in Simcoe.
Deb, there's one in Simcoe. I thought it was. I don't know that Simcoe has a heart hub. They have a RAM clinic.
Yes, sorry, that's on Ram Clinic, yes.
Yeah, I was talking about a heart hub. Go ahead, Cynthia, then Melba.
Again, forgive my ignorance. This isn't my area at all, but generally, there's always been this argument, a jurisdictional argument between the federal government and the provincial governments when it comes to services to First Nations communities. The province saying under the Constitution you're responsible for Indians and their lands, and then under this same Constitution they turn around and say, well, the provinces are responsible for healthcare. Does that enter in it? It just seems peculiar, as my pal across the way said, makes us spitting angry that we didn't get one in the example, somebody in Toronto got 7. Does that enter at all, do you think, or is that not related at all?
For the diagnostic clinic, that's totally separate, but I find that our programs have historically been caught in that gray area between the feds and the province, where they point to one another as you're responsible for First Nations on reserve. So it does create a lack of funding for us because we're basically waiting for somebody to offer the funding to us. We make the applications. You know, Abby mentioned that we were turned down even on our primary care application because we didn't have the correct postal code that they were looking for. And yet the statistics show that it's a huge need in our community and all First Nations. Primary care, mental health and addiction services. We're highest on the list, but we are not getting funded for it when we're submitting these applications. And then to be told that we don't get a reason why. Follow up.
Thank you. I was suspecting that, but I didn't know. Again, this is not my area at all. But this had been the case with the social services. Same darn thing without me repeating it. And you know, the feds every year have those annual meetings with the province's leadership, and they have an agenda. Well, way back in 1965, Dean, on the agenda was this whole jurisdictional quagmire, and there's, as a result, no services on First Nation social services, period. So they entered this whole idea of cost share, which any province could take up, just Ontario did. For the longest time, there were only social services like daycares and you name it in Ontario, and the rest of the provinces would say, "What's with Ontario's got all this?" But I'm just wondering, just using that as an example, the structure, of course, could be totally different. Has there been an initiative, or do we at Six Nations press forward with initiative through, I don't know, the Chiefs of Ontario, the AFN? I think this is one where we wouldn't be as successful going it on our own as with the others, because the other First Nations would be the suffering the same as we. But it, like, there is an answer, and it just seems like you say they just pointing fingers. No, it's you. No, it's you, which doesn't help anyone. I don't know if there's been any advancements or any thinking in that direction.
I think the advocacy is the biggest thing that we're asking for. You know, having said that, the province and the federal government, they have mandates as well that they have to stick by. So some of their funding is not available to us because of their mandates for it. However, like I said, you know, we've gotten in positions where we didn't qualify for whatever reason. And, you know, we've reached out with our needs, but it may not sit in the wheelhouse of the ministry, or it might not sit in the wheelhouse of ISK. So we're caught running back and forth between the two to try to make it fit for our community.
I had follow up.
Exactly, that's the issue. But I mean, we know what the issue is. It's a jurisdictional issue. But have there been any advancements? I don't know, through the committee to try to press that on through council, through Six Nations itself? We tend to have to speak for ourselves generally, but this one is more, would be a national offering. So a national offering, and maybe only the province might take it up if they could see eye to eye in it. But it's been done before, but not in a health. That was more my question.
I think for sure, you know, because it's on a bigger scale, and at the Chiefs of Ontario, Iroquois Caucus, you know, and even at the FN for everybody. So I have Melba, then Amos.
Yeah, Amos has mentioned Toronto. I'm not aware of Toronto, but I'm pretty sure that Hamilton received 7 approvals. They actually had details of their program and how it's operated, who's the directors and who else is on staff and what buildings they use, and also the streets of the buildings. So I think it would be worthwhile to get a presentation here where not only we understand more, but the community understands more how we are left out in all this funding that can house our people for the opioid healing process in our cultural ways. So hopefully we can do that. Thank you.
Amos, then Helen.
Yes, that's why we've been getting our ducks in order so that the council can now start advocating, especially the office of the chief. We did have a couple of resolutions that we're looking at, that we need to organize a meeting with Jane Philpott, the lady responsible for primary care in Ontario right now, and also the minister, what's her name, Sylvia Jones, either together or separately, chief. We need to have a delegation and go and talk to them and cite all of this evidence, right, that we're not getting response for. We have to know that in Ontario there are 2,500 doctors needed right now. And there's like over 25 million people, 2.5 million people who do not have a doctor in Ontario. So we bring that back to the local level. We have 15,000 people on average on the reserve based on the work of Zach and his team. So then, and generally they want doctors to have a client list of 1,000 patients in their office, in their practice. So that means we should have 15 doctors here, right in this territory. And we have 2 maybe or 4, right? 5? Okay. So we need more doctors. And I'm glad they're going to invest in young people to become in that medical profession. It's what that Abigail cited. We need to encourage and invest young people to become doctors to service this community. So I'm glad we have this data now, and we can start promoting it internally at Six Nations that, hey, you guys, you got to go to medical school to help our society, right? The other thing that has come to my attention too is that we don't have a walk-in clinic here, or an emergency care clinic, or an urgent care clinic here, or office. We don't have that. Yet other regions in the province have that. So we need to really remind Jane Philpott and her staff or Sylvia Jones, we're way behind, and get us back to 2025. So we need to frame these bullets for you, Chief, to go and knock on this door and let's go to Queen's Park and start hammering the door there. So I think we need to build a strategy with your team, Chief, your staff, and go forward. We have the ammunition now, and I think we just need to do it.
Oh,
So I just thank Deborah and Abigail and the staff there at Health for bringing this to us tonight. I know we had it last week in our meeting, and I'm so glad that we were able to get it on the agenda tonight. Thank you very much.
Go ahead, Deb.
I just wanted to make a correction about the population. I know Amos mentioned 15,000 on reserve. However, what we see is a lot of our community members that live off reserve coming back for service. So the population that we're actually serving is more in line with our total band membership, which is approaching 30,000 people. So the majority of them live close enough that they can return home, and that is what we're seeing. In addition to that, you asked about a walk-in clinic, and we are hiring more of our own Indigenous physicians. Again, the issue is space. We don't have the infrastructure to create what we want to create. And I'm going to go back to our Haudenosaunee Health partnership with Colleen Mentor and Michelle Jonathan, Dr. Amy Mentor. That application that they put in included the investors wanting to invest in putting up a facility to house our diagnostic clinic, which would not only include that, but would also include space for other items. So, we talked about urgent care and walk-in clinic. We recognize the need is there. We just need the space to operate it. We're getting the people, our young people are getting educated. They're coming home. They want to work here, and we want to employ them. Space is our issue.
Helen?
No, I was just thinking this falls in line with what Hazel had put forward a couple meetings ago about setting up a delegation to go and start looking for money and funding and finding out why they're not giving us these things. So I really think we need to work on that, to get that delegation together and go start banging on doors. Tables. We're not going to bang doors. We're going to bang on tables because we're getting in the door. And we need to start doing that. We're not doing that. We're not taking delegations to Ottawa to look for money. And Greg had mentioned this afternoon in our meeting that Ganawagi, their council is full time. And they all have their own office, they have their own staff, and all they do is sit there mainly sit there and look for money. That's what they do because they're sitting in the office all day. You have your meetings at night probably, but they just look for money. And that's what we need to start doing. We need to start doing that. Anyway.
Go ahead, Linda, then Hazel.
Yeah, I just wanted to thank Abigail for your presentation and your data, because it certainly will support advocacy. And just a reminder to council, I mean, Chief's office was tasked, I believe, early spring to secure meetings with Dr. Philpott. We had secured it and it was delayed. And we did request a meeting with Minister Jones, but we were unsuccessful in getting a delegation at AMO. But now that we have actual hard data, and we have since requested a meeting with Minister Jones as well, we sent, the materials that we had prepared to present to her at AMO in Ottawa. So this will be just what we need, I guess, to seal data in terms of the next meetings. Just wanted to share. Thanks.
Hazel, and then we'll go back to the presentation.
Yeah, I just want to suggest that we have heard whereby with Colleen and Michelle and the people that want to put up a well-being, state-of-the-art building here on Six Nations. And because we are in such dire straits with not having space to move forward with some of the things that the well-being wants to accomplish, why can't we make a decision to allow them to go ahead and put that building up? Because all we're going to have to do after the fact is pay rent till it's paid back, and then it's ours anyway. So to me, it's moving forward instead of staying stuck based on infrastructure and the lack of it. Thank you.
Okay, go ahead, Abigail.
So for the final recommendations for Six Nations and the Department of Wellbeing is that we use the Auditor General report findings to advocate for local needs. We should identify key priorities for the community and establish action plans with the Ministry of Health and Ontario Health. We advocate for substance use disorder indicators to enhance monitoring and public reporting, and to expand our local data to show the impact of utilizing traditional approaches for treating opioid use disorder. And then quickly, I gathered some data from the Data Analytics and Insights Department, and I wanted to highlight our current state of substance use on Six Nations. So, emergency department visits for overdoses specifically, out of 100,000 community emergency department visits, 633 of those were for overdoses, and this is in comparison to Ontario's rate of 10 overdose visits per 100,000. This shows that our emergency department visits for overdoses is significantly higher than the provincial average. For hospital admissions specifically, per 100,000 community hospital admissions, 23 of those were for overdoses, and this is in comparison to Ontario's rate of 1 overdose hospital admission per 100,000 visits. So this shows that overdoses in the community are substantially higher than the rate in Ontario, and that this suggests that overdose incidents are more severe or more frequent in Six Nations in comparison to the province. This next chart shows substance-related healthcare utilization by drug type. The purple line is for opioids, the blue line is cannabis, the yellow line is stimulants, and the black line is for multiple drug use. And this graph shows that there's significant rises in opioid and cannabis-related cases. For demographics, the data shows that the population most affected by opioid related cases falls within the 25 to 44 age range, and this was evenly split between males and females. For substance-related healthcare visits in infants less than 12 months old, I just wanted to highlight the purple line, which is the drug dependence and drug addiction. So since 2009, there has been a consistent increase in the number of substance-related cases of infants diagnosed with drug dependence. For children and adolescents, 67% of events in children are due to cannabis poisoning, and that has occurred in the last 5 years. And then most substance-related events in adolescents were due to poisonings, so 66%, while the remaining were due to mental health and behavioral disorders due to substances. In young adults aged 18 to 24, 62% of substance-related visits in young adults were due to mental health and behavioral disorders. Of 87 visits, 39% were from opioids, 28% from multiple drugs, and 18% from cannabis. Adults aged 25 to 54, of 360 visits, 52% were due to substance-related mental health and behavioral disorders. Males were slightly more impacted than females, and the most common indications of mental health and behavioral disorders are related to opioids and multiple drug use. In seniors, 55 plus, 55% of substance-related visits in seniors were male, and 44% of substance-related visits in seniors were female. 62% of the substance-related visits in seniors were due to poisoning. So what does the data tell us? That substance use is prevalent in all population groups across the lifespan, and this means that access to treatment and different treatment options need to be accessible across the continuum, and it highlights the need for increasing cultural and traditional interventions and being able to demonstrate its ability to improve outcomes for First Nations people. And for the final closing, we recommend that Six Nations utilize the Auditor General report findings and our community's data to strengthen our advocacy with all government partners to build up our mental health and addictions response. And the final quote that I wanted to leave you guys with is that First Nations are leaders in building responsive and equitable health systems that meet community needs.
Thank you for that. Thank you for. Yeah, and you can, because it's sad, totally sad to see when you see it in numbers of what's going on. And not having got denied for a heart hub, got denied, that's just totally unacceptable. And I'm glad that you're asking why, because those numbers just show. And I think that's the other part that I've really stressed over, especially this term, is I'm tired of seeing people suffering in silence. Because I think that's the part there is what's happening. And it shouldn't happen. And by doing what we are going to do, advocate and the push from what Amos is saying and the data and stuff, we can break those things so people don't have to suffer in silence anymore.